public health, and not just with law itself.
Hi everyone, I'm Dr. Faisel Syed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care. Today, we're talking to Corey Feist and Dr. Stefanie Simmons from the Dr. Lorna Breen Heroes Foundation about Healing the Healers, Advances in Physician Wellbeing. Let's get started.
Hello, Dr. Dan. It's good to see you.
Good seeing you, Faisel.
And welcome, Dr. Simmons. And look, we have Corey Feist back on again. How many years has it been? We first connected, it was early on in the pandemic.
Yeah, it was. I recorded this last time. I think I was in a roadside hotel in Hershey, Pennsylvania. So I'm just really glad not to be at a roadside hotel right now. And also to be with you all today. Thanks for having us. Appreciate it.
And Dr. Simmons, welcome. Thank you for joining us.
It's a pleasure to be here. Thank you.
We always like to start off with a question. And earlier today, I was talking with Dr. Dan and, especially our target audience, we're trying to target students, residents, people who are interested in trying to make a significant improvement or impact with the status quo so far as healthcare delivery is concerned. And what we have found is that with the students in particular, and maybe it might just be a medical thing, I don't know, but we love stories. Maybe start with Corey, if you wouldn't mind sharing what motivated you to dedicate your life to improving the mental health and well-being of everyone in healthcare.
Well, yeah, thanks. And, we're inspired by our students as well. We have all these student members of our foundation that have created chapters across the country, primarily in Virginia, but also expanding across the country right now. So I'm with you on the stories. So, as the story of Dr. Breen and her tragic suicide, it was really the feedback from the healthcare workforce that lasted over 3 years at such a high volume that was really what caused me to refocus our efforts, my efforts specifically. Remember that I came from a background of working within an academic medical center devoted to improving the operational lives of the clinicians in this academic medical center. Having a lot of experience working on getting the rocks or the pebbles out of the shoes in the day-to-day environment, I actually worked with Dan quite a bit in those efforts. Learned a lot from Dan. No one's ever said that on this podcast. I'll be the first one to say. Learned a lot from Dan. And something Dan didn't tell me, though, was this whole mental health secret that healthcare workers have to hold tight. And that was the piece that really opened my eyes. So it was that. And then what I learned, you said stories, what I learned very quickly was how fast the story of Dr. Breen and her career, her life, her tragic ending was motivating people and inspiring people to do something different. And so it's been her story that catalyzed all of this in the first place.
When we first read about it, and that was at that time when there was just so much helplessness. I mean, prior to COVID, we felt so helpless working within all the struggles of the system, few visits per patient per year, so little precious time to try to make that connection, to try to influence. And then we got hit with COVID. And on top of all the issues that we had before, now you had supply issues. You couldn't even speak up. You had any questions? I mean, it drove so many into such a dark place. Dr. Simmons, how long have you been now working with Corey?
I've been working with Corey a little over 3 years, first as a board member of the Dr. Lorna Breen Heroes Foundation, and then for the last year and a half as the chief medical officer.
We were reading about your history of working around the operational environments and just healthcare in general. I wanted to know some of the strategies that you've implemented to help create that. The system is still very much the system that it was pre-COVID, right? That most of us are practicing in. We get to meet doctors who are working outside of that with some of the subscription models and some of the value-based care stuff. But for the vast majority of doctors are still working within that same system. What are some of the strategies that you've worked on to help promote better mental health awareness, more confidence for us as healthcare workers and clinicians to be able to talk about our mental health and our struggles?
Thank you for that question. And, I've really been in this space for almost 15 years. And so well before COVID, there were it was a recognized issue with healthcare worker well-being and the need to address the balance between what we do in our work and the resources we're given to do that work with. The pandemic really brought to light a lot of those imbalances, but they existed for a long time, right? And so we're really thinking about those in two major buckets. And the first bucket is what is the work you're being asked to do? And the second bucket is what are the resources you're given to do that work with? And so you can break down what the solutions need to be based on what bucket you want to address. And they both need to be addressed. So if you want to look at the bucket of what is the work that you're being given to do, there are necessary stressors of caring for humanity. Bad things happen to good people. Bad things happen to unprotected, innocent people. I'm an emergency medicine physician, so I get to see that every day, right? And that's a necessary stressor of caring for and protecting those patients. Are we given the resource to do that, to care for those patients? And are we given the resources to manage the human reactions that people have to witnessing that suffering? Okay. So you can't change that work, but you can change the resources that are given. Then there's the unnecessary stressors of work. Do you have a functional electronic health system that doesn't impede the work of caring for patients, but makes it easier? I would offer that for most clinicians, the answer would be no, although there are some systems in some places that do help, right, in some ways. And I think, but I'm not going to make any assumptions, but I think all three of the clinicians on the call here probably started practice before the EHR and have seen the transition. Okay, so I'm dating us for all of the students and residents who are
for Dan, they hadn't even invented the calculator. He was using the abacus,
Right.
and then it was like, it was rough. It was rough back in the day, there, Dan.
Yes, it was.
Horse and buggy. It was unbelievable.
So, but there's also, right, there's beyond the EHR and the administrative burden, there's the systems in which we provide care. So can you get authorization for a treatment for your patient that's needed? Can you get them the medicine that they're needed? Well, you have to medically bankrupt someone in order for them to have their life saved or their life improved, right? And all of those unnecessary stressors, they cause moral injury to healthcare workers who have dedicated their lives, certainly their 20s and a good chunk of their 30s, right, in building the skill set and the career in order to be able to take care of and heal patients. And when there are things in between being able to take care of and heal patients, that's a problem because you're seeing the suffering in front of you. You have the skill set to impact that suffering, and you're impeded by the structure around you. So you need to have solutions that are changing the work, meaning reducing the inefficiencies and the barriers to patient care, and also increasing the resources. And those can be personal resources in terms of training on how to manage the necessary stressors, or they can be organizational resources to put more resources into place to do the work that's available.
There was an article in the New York Times yesterday by David Brooks. I think he was talking about more of just sort of the insanity of the world we're living in. He wasn't talking about healthcare specifically, but the title of his piece were "You're Only as Smart as Your Emotions." And he made he said, my core point here is that you need to be a great emotional athlete in order to make the great decisions in life. You need to be ardent enough to feel and astute enough to understand your feelings. Life is not a series of calculus problems. Life is about movement, moving through different terrains and circumstances. Emotions guide the navigation system. Yet it seems like when we're training to be doctors, it was how do we ignore our emotions? How do we ignore our emotions and show up early in the morning and be willing to stay late and skip meals and honestly skip bathroom breaks, right? So what are your thoughts about that? How do we work on this piece of it to say it's okay to have emotions? And in fact, it's not okay. It's going to be very difficult to do well unless you start tuning into your emotions and listening to them, that will make you a better doctor rather than a worse doctor.
For many years, my title was Vice President of Patient and Clinician Experience. And the reason those two, right, were together, patient experience and clinician experience, is if healthcare workers don't have the resources they need to attend to their own needs, right, both work resources and personal resources, there's no way that they can provide the compassionate, appropriate care to the patients in their patient panels and their population that their patients deserve and expect. And so you're right. You're absolutely right. Emotional intelligence is absolutely key to both a happy, successful clinician population, but also successful, compassionate care.
Yeah, I remember my intern year, we just got the computers, but everything was still handwritten. All our charts were, so we still get the binders, or we go to the nurse's station, we're making rounds, and people would interact with each other in the hospital, right? But, we're making rounds, and I wouldn't, the nurse from overnight or the tech from overnight would come and say something to me, hey, while you're making your rounds, I just want you to know that this happened and that happened. I said, oh, thank you so much. And then somebody else would come, and we all kind of congregated at the station, and we were able to kind of work with each other. I might see a specialist across the way, and I'd say, hey, what do you think about this? I got this. I'm thinking about that. Oh yeah, there was a lot of that interaction that we don't see so much anymore. We don't see so much of that interaction because people are now having to document or figure out ways of how to document, in the computer, or they're working remotely from home, and we're not having that personal touch as much, unless the center or the hospital, wherever you're working at, encourages more of the random mingling, the beautiful mingling that used to have, the curbsiding that used to happen. People knew, this person is a nurse, this person is a tech, this person's an intern, whoever, and we would all work with each other to help the patients, right? To help patient care. And so I feel like that's another huge piece of it. It's lagging in our world. Everywhere else, it's amazing what we're able to do right these days. But when I speak with my non-clinical neighbors or my non-healthcare neighbors and friends, and I'll tell them about some of the struggles with trying to get something just so simple done, like an authorization or approval, it kind of looks like, my gosh, I just got my mortgage without talking to a human being.
Well, we're still operating on fax machine. Don't forget that. So, it is a little bit out of date.
So just the integration of the technology is still very much a barrier to the doctor to team relationship, the doctor to doctor relationship, the doctor to patient relationship. These three core relationships to be able to have an effective healthcare delivery system. Well, the exciting news is that, we're meeting people who are, using the technologies that are with the artificial intelligence to take in information and spit out all whatever the bean counters need to be able to have their billing, but we're still not there yet.
Well, let's talk a little bit about that human interaction component, because there's all sorts of different relationships within a work environment that are important. And, listen, I used to have a t-shirt, and on the front it said ER doctors save lives, and on the back it said ER nurses save ER doctors, right? And so by transitive property, ergo, right? But that only works if you're having a conversation. And I would argue you don't just need to know the role of the people that you're working with alongside, you need to know their kids' names and what's happening in their lives, right? Because that's going to help you interpret their actions and what they're doing in the team. And our leaders also need to know that about our team members. So what we know about professional well-being in the healthcare setting is that proximal leader has the biggest impact on the well-being of the people on that team. So yes, you need to address institutional stigma. You need to remove barriers to giving care. You need to provide people individual resources. And you cannot forget the importance of that proximal leader. And so for learners, thinking about how they develop their leadership skills as they develop their diagnostic and therapeutic skills, right, is really important. And then for folks who are in those leadership roles, our healthcare leaders are experiencing burnout at a rate that is as high or higher than folks in healthcare who do not also have leadership roles. So thinking about how we can additionally support their leadership development and their skill set there is critically important. I'm very fortunate to have an excellent leader. So Corey, I'm wondering what your thoughts are on this.
Just to say that by contract. It's so interesting as I've stepped back and I've thought about this, and healthcare has become it's trying to become so transactional. Faisel, you were just talking about the electronic medical record. And I remember the first time I went into a patient exam room, to a clinic room, when we implemented the electronic medical record. And I'm sure Dan knows what I'm about to say because he was probably running one of those rooms. And the computer was in one corner of the room and the exam table was in the opposite corner. And I just looked at this and I said, well, very clearly, whoever installed that is not a clinician, because that's not how the relationship, that is not how humans connect. I mean, you can technically connect by me standing here looking over my shoulder talking to you guys and staff, but that's not the preferred way to do it. But that's the way that a lot of exams are, right? You're sitting there, you're typing as fast as possible. I think about that in the context also of the consolidations in the industry, these massive mega mergers in healthcare that have just turned clinicians by and large into widgets. They feel that way. When we look at the data on physician burnout in particular, and you look at where they work relative to being most and least burnt out, the most burnt out are all in these big systems where by and large they feel like they are widgets. The least burnt out are in independent practice or small groups where they have autonomy and agency. This is about human connection. This is about that relationship, as Dan, you were talking about. And I never was trained as a physician, but I know what you're talking about. Sitting around the water cooler, having a conversation, just as Steph was saying, checking in on your friends and your family, recognizing that this is a team sport here. I want to just say two other things about this, which is I think that one of the biggest problems that I would observe as an outsider to the way that healthcare is trained and then delivered is that we really are relying on our workforce to be heroic. We are relying on them, and we reinforce within every aspect of the training that you are heroes. You have to do just what Dan was saying. You can't go home. You can't even go to the bathroom. I mean, I remember a close friend of mine, when she was a resident, she was pregnant with one of her children. She had morning sickness and she would walk around morning rounds with a solo cup so she could vomit in the hallway and throw her cup out and then, pop some gum in and keep going. That is not normal. That is not the way that most industries operate. And yet, because of our processes, because of how we've tried to turn these humans into not just heroes, but also widgets, we've dehumanized a lot of this. When you were asking before to Steph about what solutions we've seen, one of the things that came to mind is what we're trying to do is we are trying to take back the night for our healthcare professionals and get all of those things out of the way that get between a healthcare professional and a patient. And there's actually a ton of opportunity to do it. And I'm standing in my office, and just outside my office is my wife's garden, and I'm looking over there, and there's a lot of weeds that have crept in over the summer that we have not bothered to prune. And I think the administrative burden that has grown in healthcare, particularly and then shifted onto our healthcare workforce, needs to be pruned way back. It's possible. We've got the shears to do it. We've got all the data, the research, the science to do it, but we've got to take this back, because what we've learned is in the last year is that healthcare professionals, as compared to any other industry segment in the country, have the worst mental health. We have a mental health crisis among our healthcare workers. We have turnover. I mean, we have intent to leave now by many, the highest it's ever been. Burnout, the highest it's ever been. Violence against and threats against health workers, the highest it's ever been. And I come home every night and I talk to my wife, Jennifer, the co-founder of the Lorna Breen Foundation, and I share another story. And she just keeps turning to me and saying, why would anybody go into this profession? And the reality is that if we don't take back the night and we don't start to implement these common sense solutions to bring more humanity back into the practice, stop treating clinicians as widgets, and take this over, we won't have enough healthcare workers to take care of us. Think about the fact that a third of new nurses leave the profession entirely after just practicing for 2 years. It's not because they got a better paying job. It's because the workplace environment is not what they signed up for. And I think that physicians, frankly, would probably be in that same boat, except they got to do the whole medical student to residency to fellow, and oh my gosh, now I got to start paying back all this enormous debt, right? They'd probably be leaving faster, except they probably feel like they don't have any other option. Not trying to be Debbie Downer on the situation. Actually, as we see this, innovation in healthcare is now thinking about the impact of the work on the workforce, using existing common sense tools, practical tools to do it. But it's going to take leadership, which Steph was talking about, to recognize this, to value it, and to prioritize it so that the workforce can just simply do their job and what they trained for.
And I know you've been doing some work from the policy standpoint. There's a picture of you with some very influential politicians, and we don't want to really get into politics, one party or another, but I mean, it is going to take some work on the policy side. What are you doing on the policy side to help make it a better place to practice?
Here's what's amazing about that picture, any picture you would show. It's all bipartisan. This is not a partisan issue. The reason why the Dr. Lorna Breen Healthcare Provider Protection Act was signed into law by President Biden on March 18, 2022, surrounded by members of both parties, and did it in 2.5 years when most new law takes decades to fruition, is because this is a bipartisan issue. And because there's so much to do, there's so much room for agreement, is actually so much that can be accomplished without even getting into those third rail issues that one party or another would want to do. And so a couple thoughts. There's work on the federal level. There's work on the state level that can be done. There's work on the local level. And what folks need to understand, I think, is the number one driver of burnout of physicians in particular, pre-pandemic, during the pandemic, and post-pandemic, is administrative burden that they carry. And that administrative burden really comes into play in the electronic medical record. It comes into play in the prior authorization work. Both of those things and everything that's in the electronic medical record is driven in some way by a decision that either a policymaker at a state, federal, or local level made. Right? Either your hospital decided you needed to document in a certain way, your state Medicaid program or your state programs said you got to do prior authorization one way, or the federal government said it one way or the other. And so one of the things that we are actively pursuing as a foundation, and people can get involved in this at their state, federal, and local level, is just to understand who's got control about which administrative burden, and just start to peel it back. In addition to that, we are focusing on trying to understand more about who needs to know what to do what. Well, that was a really concise statement, Feist. Let me dissect that a little bit. The Lorna Breen Act is being reauthorized right now for another 5 years. It was initially put into place for 3 years, and now we're already at the third year, and so we're trying to extend it for 5 years. The Lorna Breen Act has two streams of work. The first stream of work is for direct grants to hospital systems so that in this next iteration, they can start to focus on reducing the administrative burden. The other aspect of the Lorna Breen Act is the creation of what's called the Impact Wellbeing Campaign. It's a campaign that the CDC and NIOSH have led. We've helped to be technical advisors on it. That very, very smart person you brought with me today on the podcast has been the primary advisor on that. And that is a health leader-focused campaign, which gives them six very concrete segments of work to do to take back, take back the night, if you will, for the healthcare workers. What policymakers need to do is they need to extend this law so that hospital systems can continue in their local areas to get the weeds out of the garden, get the rocks out of the shoes, whatever you want to call it from an administrative perspective. And they also need to extend that so that every single healthcare leader in the United States can implement the 6 phases of work in the Impact Wellbeing Campaign, because those are they're all very practical, data-driven, and will have an immediate and long-term positive influence on the workforce. So those are just some ideas about that. And that's the way that we look at it. We look at it as who's in control? Are you a federal policymaker, a state policymaker, or a local policymaker? I'll add one more quick thing. The other thing that is, in addition to the operational side, we have this mental health crisis for healthcare workers. We talked about it. Did you know that if you're a licensed health worker in the United States of America, you are being asked questions about your prior mental health diagnosis and treatment almost every day, which violate the Americans with Disabilities Act? Straight up, we have a letter from the Department of Justice that says that these questions about prior mental health diagnosis and treatment that go into decision-making about your employment, whether that's licensing or credentialing, run afoul of the ADA. So that's not okay. That reinforces stigma. It is one of 3 key drivers of suicide of health workers. It's what my sister-in-law was most concerned about before she took her own life, which was that she'd obtained mental health treatment and she was going to be penalized for her career. The other part of the policy work that needs to happen here should follow the model that we led in Virginia in a bipartisan way with unanimous support from both the House and the Senate in Virginia, which was to change licensing questions to remove overly invasive questions about prior mental health treatment and diagnosis from 500,000 licensees applications in 62 different health professions. We did that work led by the Medical Society of Virginia, the Hospital Association, the Nursing Association, and I got to testify in favor of that legislation. And the chair of the committee who oversaw that bill turned across to his fellow committee members, and after I testified said, would anyone here dare speak against this legislation? It passed unanimously. So the hope that I want people to take away from this whole conversation about policy is that there's a whole bunch that can be done. There's a whole bunch that will be done in a bipartisan way. This work will have a huge positive impact on the workforce.
Wow, Corey, thank you so much for that, for just sharing. I mean, that alone has given me I knew that there was some incredible work being done. We meet, Dr. Dan and I get to meet a lot of young students. We have over 5,000 residents in our learning community. And so a lot of the problem is us too, like this multi-generational stigma that has been passed along. So a lot of it's going to have to come. Dr. Simmons, you were mentioning about us as the leaders or, whatever, like the ones to kind of lead that change,
Absolutely.
Kind of to speak about these things. Like we have to be the ones to help drive a lot of those conversations, because even if all this great work is being done, but then we ourselves kind of continue this generational sort of, we don't talk about these things. I mean, I didn't even know about what he was saying with the ADA and not answering those questions. I'm in both, actually, Dr. Dan and I, in a career change phase of life right now. And it was something that, I'm sure probably Dr. Dan knew, but I know I didn't. So there's a lot of work that we can do too, especially as physicians and physician leaders. Absolutely.
And so the invasive and stigmatizing language that's used on licensing and credentialing applications is a great example of institutional stigma. It's how things are done, right? That and someone at some point put those questions in because they thought they were going to protect a patient. But what we find over and over again is that if you answer yes to those questions, nothing happens, right? You don't receive more care or counseling, and you're not necessarily prohibited from patient care. It's just if something additional happens, then they have that information right to act on. So basically, you're asking a question that doesn't make an impact on protecting patients, and quite the contrary, puts patients at increased risk because healthcare workers don't want to receive care for their mental health or for their substance use because they're worried about having to report diagnosis and treatment instead of having to report impairment. We should all be reporting impairment, right? We don't want impaired clinicians caring for patients, but we do want people with mental health and substance use disorders getting diagnosed and treated. And we know that healthcare heroes, right? And please note the air quotes, right? Because we know that word is not, we're healthcare humans, right? So we know that the healthcare humans have the same rates of mental health disorders and substance use disorders as the rest of the population, if not higher rates. And so we really want people to be diagnosed and treated. But as you mentioned, Faisel, like institutional stigma is not the end of the stigma we experience in healthcare. There's internal and external stigma. So what's the difference between those two? Well, internal stigma is, what do I think it means about me if I need help? What does it mean about me if, as a caregiver, I need care? Does it mean that I'm not a good doctor? Does it mean that I'm not competent? Does it mean I'm not a leader? And it's all of these beliefs, all of this skill set you develop as a physician, that you're a perfectionist, you're hardworking, you're self-reliant, all of these skills that are positive skills that you develop during the course of your medical training and even before to get there. They're like a hammer in your tool belt. It's great if you're trying to hammer in a nail. It's not so great if you're trying to like serve a cup of tea in China, right? And so you need to have a different skill set. So you can't use the things that got you there to get you out. And that's where the internal stigma comes in. The second part of that is external stigma, because we care for patients with mental health issues and with substance use disorders as healthcare workers. And the language we use for our patients is not always language that we would want to have applied to ourselves. We can be very thoughtful about the language we use when we talk about our patients with substance use disorder, our patients with mental health issues, by putting the person first and by recognizing that the conditions that they struggle with are not moral failings, but medical conditions just like diabetes or hypertension. And so when we start to talk about our patients in a way that we would want to talk about ourselves or our family members, when we start dismantling the culture around having to be perfect, then we start addressing not only the institutional stigma, but the internal and the external stigma that impact people's willingness to seek mental health and substance use disorder care. And you mentioned at the very beginning of our conversation the importance of stories. And I think the importance of stories is, it's how we learn in medicine with case studies, but it's not just a medical thing, it's a human thing, right? And so if we can also share from a position of leadership as attendings, as senior residents, as folks who have experience, who are helping to model, right, for learners, if we could share how we positively deal with the stressors of our job, that if we've seen a therapist, talk about seeing a therapist, if we've had a mental health issue or a substance use disorder and have received treatment and have had a positive experience with that, sharing that story also helps to dismantle that stigma.
Do you have what's been the most positive change you've seen since you've taken this role as chief medical officer? Where a place that's doing something really fabulous, or something that you think they've really made an improvement here, a different kind of AI instead of artificial intelligence, talking about appreciative inquiry here. Give us a good example of where it's going well.
Well, to me, one of the most heartening things that I've seen in just the past year and a half has been the transition of going from 14 states that were consistent with best practices around state licensing questions for physicians. This fall we'll be announcing our new map to 60% of states. That's a huge shift. That is quick change, something that you rarely see in either politics or medicine, and positive change based on best practices and best evidence. To me, that is a sea change in how organizations are thinking about the mental health and the professional well-being of their healthcare workforce. And it is significant in and of itself, but it is even more significant as a signifier of what the culture is willing to do to protect patients and clinicians together. Okay, now, if you ask me about what is sort of the other big cultural change, I'd say the medfluencers, okay? The physicians, nurses, pharmacists, techs who are on Twitter, on Instagram, on TikTok. The fact that it took me a second to think of TikTok, sorry, any Gen Z folks who are listening to this who are medical students right now, clearly I'm not. But these folks are telling their stories. They are destigmatizing mental health care. They are sharing how things can be better. And so these aren't necessarily changes that are happening within the four walls of a building. These are cultural changes, and the cultural changes are going to pull along the organizational changes, because culture can change actually a lot faster than institutions.
Thank you so much, both of you. I mean, if you're someone listening, you're in healthcare, even if you're not in healthcare, I hope that this conversation with both Corey Feist and Dr. Simmons, if you're struggling with your own mental health, I hope that this conversation makes you feel a little bit less hesitant to seek help Thank you both so much. I really enjoyed this conversation. It's so refreshing to hear people, we hear so many people complaining about all the problems, right? But to have two people here so dedicated to improving the mental health and well-being for everyone in healthcare. And what good are we to our patients if we don't take care of ourselves first? So thank you both so much. Your work is truly making a difference.
My pleasure, Faisel.
It's an honor. I've just got to put a plug in for 988 because you were just talking to people that maybe need a number. 988 is the new 911 for mental health for the country, and it is making a huge impact. And so as a last resort, don't hesitate to call that number if you need it. We know it's saving lives every day. So Faisel, Dr. Dan, it's great to be here with you all today. Thank you for creating space for us in this conversation and creating space for the humanity to return to medicine. We desperately all want it to be there, and we're just happy to play a small part in making it happen.
What are your thoughts on Healing the Healers, advances in physician well-being? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.